welcome everybody to tonight's Zoom meeting. Today we have the great honor of having one of the outstanding doctors at UCLA, Dr. Abdelnawar. She is medical director of the UCLA Living Kidney Donation Transplant Program. And tonight she's going to be giving a wonderful talk. It's entitled Kidney Donation, Saving Lives and Protecting Donor Health. So Dr. Abdelnawar, I want to thank you so much for taking the time to do this, and we look forward to your presentation. Thank you again.
Absolutely, my pleasure. Thank you, Dr. Kurtz, for inviting me to this session and to talk about living kidney donation. It's a topic that is dear to my heart, and we practice every day. We look after donors' health and how we can optimize donor workup and take care of this generous population of people who want to give an opportunity of a better life to others. So we'll start my talk by outlining the topics we're going to talk about: history of living kidney donation, why living kidney donation, what is the medical evaluation of living kidney donor, what are the exclusion criteria, some ethical considerations, and multidisciplinary approach with some final thoughts. We can't talk about living kidney donor without highlighting the very first living kidney donation in human was done in 1954 by Joseph Maury, who did it on twin brothers from a live donor to a live recipient, and he was recognized for this accomplishment 36 years later, won the Nobel Prize in 1990 for his approach of advocating for the life donor and moving a kidney from someone who doesn't need a surgery to the recipient who was in need for kidney transplant. This is a picture 1 year after transplant of the brothers, Richard and Ronald, 1955. And you can't tell who's the donor and who's the recipient. They both look healthy. They both look happy. And that highlights the importance of kidney donation. It's a win on both sides. And we'll talk more about the feeling of the living donor after donation and the feel of impact they do to the recipient life. The donor Ronald lived till long life and died at the age of 79 from heart disease, so not even related to kidney disease. I want to also highlight that the first living kidney donation happened, or living kidney transplant, happened at UCLA in 1960, so just 5 years after the very first kidney transplant done in the United States. And 7 years later, we had a very remarkable story. A father who back then was 39 years old lost one of his daughters to a rare genetic disease, and the other daughter was suffering a kidney disease, and the options were limited for her. So he opted to donate a kidney to his daughter. And yes, often we say the kidney doesn't last for life, and there is a short lifespan of kidney post-donation for the recipient. But this kidney lasted a long, long life. So this is a picture of the father and his daughter. The father at 96 years old and the daughter at 70 years old, 56 years post-transplant. And the transplant is going well. The daughter remains healthy, and he's just in a good health, but of old age. So that was a remarkable story for a kidney to last 57 years without any problems. So we want to talk about the options of living kidney donation, living kidney or kidney replacement therapy in general. Once a kidney reach an end-stage renal disease, the patient have limited options. The dialysis in general, in different versions, whether it is a peritoneal dialysis, hemodialysis, or home hemo, and the other option is the kidney transplant. A kidney transplant generally offers more freedom and better quality of life for patients. So many people opt for kidney transplant if it is a viable option. In the transplant world, we have two options, either a living donor from someone who's alive, who's willing to donate a kidney to a loved one, or from a deceased donor. So someone who died and wished to donate organs to people in need. So why living kidney donation? We have 90,000 Americans on the wait list for kidney transplant, according to UNO statistics of March 2025. There is always a shortage of organs. As more patients are in need for kidney than organs or kidneys become available for transplant. Living donation helps to reduce the need for organs, offer shorter wait time. So instead of waiting for years to receive a deceased donor, if you have a person who's willing to donate, you can get it in a matter of 1 to 3 months. It also carry a longer graft survival and better patient outcomes. And you can see here, when we look at the graft survival, which means the kidney in the recipient do well if it comes from a living donor versus if it comes from a deceased donor. And also the patient do better if they receive a kidney transplant from a live donor versus a deceased donor. And you can see the remarkable difference. However, in the living kidney donation, it's unlike any other field in medicine. We put someone who doesn't need the surgery at risk to save someone else's life. So they go through a robust and detailed evaluation to make sure that we are not exposing them to increased risk in the future. And this kidney donation is not going to alter their life in the future by any means. This is a graph that shows the trend in living kidney donation compared to deceased donor. So you can see it since 2010 compared to 2022, the deceased donor transplant has increased where the living donor is almost plateau. And this is, simply we can say for every deceased donor, we get 2 kidney transplants, where in the living donor, we get 1 kidney transplant at a time. So that can account for the increase. But there are also other factors which we will highlight in this talk. So the evaluation, as I mentioned, of living kidney donor candidates require comprehensive exam, careful assessment of short and long-term risk factors. I joke with my patients. We have 1 patient in need for kidney who is sick. We don't need 2. So we better do a very good job to make sure they don't end up in need for kidney. The medical evaluation include a comprehensive workup. So when we see patients in the clinic, they say, well, I did 17 vials of blood that you asked for. Well, yes, we do a lot of blood work. And it's much needed to make sure they don't carry any infection to the recipient. They don't have any disease that has not been diagnosed yet, and to do a very fair job assessing their risk for future cardiovascular diseases and autoimmune diseases and infectious workup. So they go through a robust workup. We do also other testing other than the blood work, which include EKG, what we call EKG electrocardiogram, chest X-ray, some renal imaging, we call it CT urogram, and age-appropriate cancer screening. Occasionally, we do genetic testing when indicated. And the question, when do you consider patient is at risk for genetic disease? Simply when we have a recipient who is a family member with kidney disease, and is a son or daughter or a brother or sister donating to that member. Those are considered familial situations, and we have to rule out familial kidney diseases. So to protect the donors, again, the whole focus is to make sure the donor is protected and we're not gonna run into complications after donation. So we run a genetic disease on the recipient first to identify what type of gene have led to kidney disease. And then we run the genetic testing on the donor to make sure they don't carry the same gene that led to the recipient kidney disease. What other medical evaluation? Some donors require beyond the usual workup. So sometimes we ask for echocardiogram or nuclear medicine stress test. Sometimes we ask them to do 24-hour blood pressure monitoring if they present to the clinic with high blood pressure and they've never been told that they have high blood pressure. They're not on blood pressure medication. So we have certain approach to make sure they are not newly diagnosed hypertension or, and if they do, we ask them to go back to the primary care and do the appropriate workup to manage high blood pressure. Sometimes a kidney biopsy will be required, but very rarely. Cystoscopy, which is looking in the camera and, screening their bladder. We look for hypercoagulability, which means elevated risk for clotting disorders or bleeding disorders. Glucose tolerance tests for those who have multiple family members with diabetes. And we screen the African American population who come from both parents who are African American for a gene called APOL1 gene. And this is to, if they have two high-risk alleles, we warn them from donation because they are considered at high risk for high blood pressure and kidney disease in the future. But that's for certain age limits in the younger population. Now, how do we decide? And we get this question very often. How do you decide to take my left kidney or my right kidney? Well, there are multiple factors that that play in that decision. Anatomic consideration. Usually, the left kidney is the preferred one, since the left renal vein is longer than the right. But that's not a rule. The general rule that we go after is to leave the donor with the best kidney. So we study both kidneys' anatomies, we study the structure of the kidneys, and we leave the donor with the best quality kidney. And we donate the less than perfect kidney. So if the left kidney usually preferred surgically, but if the right kidney can be donated, the right kidney, if the left kidney is better, so we donate the right kidney. If a kidney has multiple renal arteries, and that's considered a surgically difficult technique to cannulate 3 arteries, for example, into a recipient. So we prefer the kidney with a single artery or maximum double arteries. If there are arterial variations, those are determined and studied by a committee, including surgeons, who look at the image and look at the surgical feasibility of each side and decide, okay, let's go for this side because this seemed to be very complex surgery. And very rarely we encounter kidneys that have more than one ureter. So remember, every kidney comes with the artery, vein, and ureter. Ureter is the tube that connects the kidney with the bladder. So if the kidney has more than one ureter, it's also considered as a complex surgery because you have to cannulate 2 ureter into the bladder, and that can increase the risk for complications. Now, another factor that play in the decision whether we're going to take the right side or the left side is the functional consideration for functional capacity of each kidney. So when we do a CT scan for the body, we look into the volume of each side. And if the kidney, one side looked larger than the other, within certain variation, we accept it. But if it is remarkably larger, we do something called a nuclear medicine split function test, which is an advanced nuclear medicine study that enable us to tell okay, the right kidney contribute by 45% versus the left kidney contribute by 55%. Then for sure we're going for the right kidney because we want to leave the donor again with the best kidney. So that's one of the considerations. If the kidney has a small scarring or a small cyst, we donate the kidney with a small cyst. So again, we look into the CT scan, we look into the imaging studies, and we take every single detail into consideration before deciding which site to donate. Now, we want to walk you through some statistics and over the years how the practice of and the approach to living kidney donation changed over the years and what led to these changes. So since 1988, the blue line, if you track here with me, the blue line represents the living kidney donation. And between 1988 and 2004, it was having a steady increase in the living kidney donation all the way till 2004. Between 2004 and 2017, you see the decline in living kidney donation. So people or transplant centers across the country, they were wondering, like, what happened? Why we're not seeing as much increase in living kidney donation? What are the factors that led to this decline? This is one of the studies that looked into it. They found that, we have rules and regulations for living kidney transplant. And the change in the deceased donor allocation system, which means prioritizing pediatric population, happened in 2005. If a transplant recipient become in need for kidney and they belong to the pediatric population, they get prioritized over the adult. And that led to the decline in the statistic because they only looked at adult living kidney donation. There's also, they found the financial disincentives that happened, with the economic crisis 2007, 2008. These living donors take time off work, and if they are in financial distress or, in financial crisis, or they can't take time off work and commit to a surgery that, result in time off for at least 3 weeks, not to speak of all the workup required prior to that. So that also played as a factor in the decline in living kidney donation. Also, a major factor, which I will expand on, is the health status of the general population in the United States. And let's talk about that. So between 2004 and 2021, this is just a heat map of age-adjusted, newly diagnosed diabetes in the United States. So you can tell how many people got diagnosed with diabetes over the years. It becomes a new pandemic: diabetes, obesity, and hypertension. So the pictures speak of itself. So this is another shape that show the hypertension-related end-stage renal disease. And between 1999 till 2020, this is the hypertension-related end-stage renal disease. So every year, we found more people that have hypertension and contribute to them being having damage to their kidneys. This is the obesity heat map in the United States that was done in 2022. And when they split it among the different population, this is the obesity heat map for the non-Hispanic Black adults. This is for the Hispanic adults, and this is for the non-Hispanic white adults, and this is for the non-Hispanic Asian adults. So the green light that you see is a normal BMI, which is a normal healthy person. The yellow that you see here represent what we call it in the classification of obesity as an overweight population. Anyone from 25 to 30, that's an overweight. And in the orange line, that's obesity stage 1 or level 1, 30 to 35 BMI. And anything beyond that, that's called morbid obesity, that they need like major intervention to bring the weight down. So you can tell that the population is not as healthy as it used to be. Now, why we're talking about obesity, diabetes, and hypertension? Because if we look at kidney disease and what leads to kidney disease in the United States, it's number one playing factor is diabetes. So patients with diabetic end up with kidney disease, and it's 38% of patients with kidney disease have diabetes. High blood pressure, 27%. And other factors, like glomerular diseases and, some neurologic complications, and so on and so forth. But rated as number one is diabetes and number two, high blood pressure. Now, speaking of that, the question becomes then, who can donate a kidney? Now, everyone can donate a kidney. Let's talk who cannot donate a kidney. So what do we consider as an absolute contraindication to kidney donation? Those who carry the diagnosis of diabetes. If you're diabetic, you cannot donate a kidney. You have to watch after your kidney health and make sure your kidney won't deteriorate because of the diabetes. So those, we rule them out. Also, the patient who have newly diagnosed diabetes during evaluation, which means they come to the clinic, they're not aware they have diabetes, and upon doing the workup, we discover, you have a glycemic control in a range that fit in the category of diabetes. So please go back to your doctor and make sure you get appropriate management for diabetes. Now, what about the individuals that read in the category of what we call it pre-diabetes, or the so-called borderline diabetes? In the general population or in the young population, they're absolutely not acceptable because they have higher risk of developing diabetes in the future. However, this rule might be liberalized for the older population, the more senior population, meaning that if I have a patient who's 27 years old and come with pre-diabetes, we cannot accept that donor as a potential donor because by the time she hit 50, probably she or he hit 50 years old, they become diabetic. Where if they are in the 55 or 60 years old and they have pre-diabetes and no other complications or end organ damage, then we probably can move them forward with the caveat that we do a robust education, we do consent from the patient, we make sure they're aware of the risk and they're going to take care of their health, not to develop diabetes in the future after donation. I like to go over cases that we consider as an absolute contraindication. So when you submit an application to become a kidney donor, these are some of the criteria that rule you out before you see a physician. So if you have an evidence of renal disease, your kidney function estimated as below 80 ml per minute, or if you have proteinuria or albuminuria, as these represent kidney disease. If you have a significant renal or urologic abnormalities, like you have recurrent UTI, bilateral kidney stones, and so on and so forth. If you have HIV, hepatitis B, or Chagas disease, since these are very hard to control and treat in the recipient, and they are very highly transmissible to the recipient. So we try not to accept donor who can be creating problems for the recipient. They are already dealing with immunosuppression. So if available, if other donors available, we prefer alternative options. If the donor has active malignancy, for sure, we're not going to accept a patient who have malignancy. Poorly controlled psychiatric illness. We ask if you've been admitted to the hospital for depression or an anxiety attack, if you have had recent suicidal ideation. That doesn't mean all patients who take antidepressant or anti-anxiety are ruled out as potential kidney donors. We assess the risk and we make sure they're not gonna have a major breakdown after kidney donation. So that's the focus. Again, it's a complex process. So they go through a medical evaluation and then they go through psychiatric evaluation. If you have cognitive deficit, we prefer not to take your kidney since the consent can be unreliable and you might be under pressure, so you're not able to make your own decision. And if you are dealing with current pregnancy. Uncontrolled hypertension is considered also not suitable donors. We ask them to go and try to control blood pressure. And if they get it under good control without evidence of end organ damage, we might move them forward in the process of donation. If they have diabetes, which we highlighted, or kidney stones, if they have clotting disorders, we recommend against donation, since that can be, the surgery might trigger blood clot. And then if they are too young, under the age of 18, it's considered an absolute contraindication. And I'll highlight more about the age criteria down the road. And if we have high suspicion of donor coercion, like pressure or money or financial profit from the donation, we do not accept these donors. If we have high suspicion of illegal financial exchange between donor and recipient, we also consider them as not suitable for the donation. Now, regarding the age, they did a survey among all transplant centers in the United States. And between 2005, the light gray, and the 2017 is the black column. And vast majority of the transplant center accept patients who are 18 years old or older. Some of them accept 21, and few of them accept 25 or older. Well, we at our center, we go for 25 or older, because we consider the young population too high of a risk, or a lot of unknown risk that might happen down the road. So by taking a kidney from a very young person, we're placing them, or we're taking a risk of what if they develop diabetes, high blood pressure, what if they gain weight and become obese, there is a lot of factors that can, complicate their health status down the road. Where in the upper population, this is the two end of age limit. In the upper population, we have no limit, no upper age limit for who can donate a kidney. The oldest donor, I think we accepted in the 80s, but they must be healthy and in good shape. Some centers will not accept any donor who's above 65. They have a cutoff of 65, some 70, and some 75. We belong to no upper age limit. So if you live to 50 or 60 or 70 and you still have good kidney function, that means you live through the risk, and there is very little odds that something bad going to happen that result in your kidney being affected. And where did this cutoff for the young population came from? In general, the brain maturation continued to happen throughout the teenager age. So people who are 18 to 20, their brain is still developing. That's why they have a cutoff for alcohol consumption till 21, because they consider the brain has not developed and matured fully till the age of 21. And, it's considered to be, the brain maturation is considered to be mature and complete by the age of 24. Now, with the caveat, I have to say, if we have a donor who applied to donate between 20 and 25, we accept in certain situation. We discuss with the committee and we run it on case-by-case situation. They have to be sibling. They have to have a family member. The recipient must be a young person. So we go through certain criteria, and there are cases where we approved donors who are between the age of 20 to 25 to donate, but nobody have donated a kidney in our center below the age of 20 years of old. So what about the hypertension criteria? So the practice has changed over the years. So what used to be considered high risk has been a little bit kind of become acceptable in the recent years of medicine. So back in 1995 to 2007, most of the centers accepted patients only if they have normal blood pressure, taking one blood pressure medication, or they have persistent borderline blood pressure or any borderline blood pressure. Now, people moved forward to accept patients who are taking more than 2 blood pressure medication. They consider blood pressure as a controllable disease that as long as you take your medication and you lower blood pressure to certain acceptable values, you can be considered as a kidney donor. So we moved from accepting donors with 1 blood pressure to accepting donors on 2 blood pressure medication, as long as they take care of themselves, they show that they take medication on time, and again, no end organ damage. Now, what about obesity? The cutoff has been 35 throughout the years, but we see some outliers. Some centers in the US can accept kidney donors with a BMI of 40. Our center cutoff is 35. So why obesity? Because obese population, or we for each unit, let's call it this way, increase in the BMI above 27, and remember we said 25 to 30 is an overweight. There is a decrease in the kidney function. So the higher your BMI, the lower your kidney function, and the higher the risk of ESRD in the future. So we are exposing patients who carry higher than usual risk for ESRD to donate, and that becomes taking too much of a risk. Now, what about the so-called GFR? So for education purpose, GFR is the measurement of how much the kidney filter or how much the kidney functions. We call it glomerular filtration rate. So back in the days, it used to be 80 as the cutoff. These days, they accept 80, and sometimes we more lean towards a mean creatine clearance with 2 standard deviation. I won't go into details into that. But why 80? Where did this number come from? They monitor over the years the recipient performance or the kidney after we move it from the donor to the recipient, how much this graft survive and how well they do. And they found out that kidneys coming from donors who had a GFR below 80, they did as much as they received a deceased donor kidney. So they no longer carry the benefit of having a living kidney donor. So this is a cadaveric donor, and this is the kidney from a patient who had the GFR below 80. And you can see here, they did almost the same performance, where donors who carry a GFR or who had a GFR above 80 ml per minute, they did much better in the post-transplant performance. Now, an 80 is a good cutoff for acceptable for the recipient standpoint. Now, what about the donor? For the donors, it differs with different age. So what is considered acceptable for a 65 to 74 years old is not the same criteria should apply to someone who's 25 to 34 years old. So the mean creatinine clearance in the younger age population is around 140 ml per 1.73 of meter square. So 2 standard deviation is 21. So plus minus or the mean minus 2 standard deviation put you in the 97. So I need at least a 97 creatinine clearance or measured GFR to accept a patient who is in the age group of 25 to 34. Where in the older population, I can accept a patient with 76 mean creatinine clearance, and they do just fine. So every age has a cutoff, and every patient become a case to study by itself. So every case is looked at differently, and we factor on all the risk factors and all the patient parameters that presented together. So why do we look at what we call it normalized creatinine clearance? Now, as doctors, we receive these numbers, and we can't just look at the chart. We have to look at the chart and match it with the patient. Let's say we measure 24-hour collection to estimate how much the kidney is functioning or filtering, and we get a GFR of 100 ml per minute for patient on the right side and on the left side. This person has a body surface area of 1.5 meters square. However, this person has a body surface area of 2.0 meters square. So if we want to normalize to the body surface area, this person end up with a GFR or calculated GFR, measured GFR of 115 ml per minute, where this person end up with 86 if we normalize to his body surface area. So although both of them got the same number on the 24-hour creatinine clearance, they get very different numbers when we looked at how the patient looked like and what is his actual height and weight and BMI. Now, I want to move to a different topic where they often, patients who want to donate their kidney, they mistaken like, what if we're not a match? And what I want to say here, the ultimate goal is to get your loved one a kidney, a good quality kidney. So we don't care whether you're a blood match or a tissue match. If you're willing to donate, apply for kidney donation. So we have multiple programs that can handle the situation where patients are not directly matching with the recipient. So the program is called National Paired Exchange Program, or NKR, National Kidney Registry, where we log in the recipient, we log in the donor, and they go through certain formula where they match the donor with the recipient in the country, and they give the recipient a kidney that matched them. And this is an amazing program. Oftentimes, a donor will donate the same day their chosen recipient is receiving a kidney, and typically around 80% of incompatible pairs get an exchange kidney within 90 days. For example, a husband want to donate to his wife. They're not a match. So he decided to donate today. 80% chance within the next 3 months, the wife gonna get a very good quality matching kidney. So that's a very good opportunity that helped and continue to help many people across the nation. And actually, I have to say, it's a mathematician who came up with the formula for the pair exchange program, awarded the Nobel Prize, and he's a professor in math from UCLA. I don't have his picture today, but you can look him up. We also have a voucher program, or the so-called advanced kidney donation. So this program is created for individuals who are willing to donate to family members that not yet in need for kidney transplant. For example, a grandfather who is 65 years old, who is now healthy and in good shape. He has a grandson, 7 years old or 10 years old. The kidney is functioning, but he knows that this kidney in CKD stage 4 are not yet in need for dialysis, but soon enough, in the next 5 years, they're going to need a kidney. So the grandfather can donate a kidney today and give that voucher to the grandson that can be claimed in 6 months, 6 years, or 16 years. Whenever they wish or need a kidney, they get activated and they go through the exchange program. So oftentimes, this advanced donation trigger a domino pair kidney exchange. So where a kidney can rotate, can trigger a whole exchange a chain to happen. And the biggest chain happened, I think, is over 100 people received a kidney transplant from one kidney, triggered a whole chain of kidney transplants across the nation. So this is a very good opportunity for people who are interested in donation, they're not matching, or the recipient is not yet in need for kidney. Now we're going to switch gears to highlight some of the psychological evaluation and social factors that we think about when we evaluate living kidney donors. So we study, as we highlighted already, their mental health, the current medication, alcohol, smoking, marijuana use. We don't have an absolute no, but we consider, we counsel them against an overuse of any illicit drugs or marijuana or over drinking alcohol. So anything within reasonable limits, is acceptable. And for sure, the ability to make informed decision. We want to make sure that this is what they want, and they don't have any pressure to do it, or nobody have promise them with money, inheritance, or positions to do a kidney donation. And if we have any suspicion, we simply say, sorry, you're not a good candidate. And young donor under the age of 25, we already mentioned this, is considered special. They have special consideration on case-to-case basis. We discussed with the whole community. Now, from a psychosocial standpoint, there are pros and cons for kidney donation. Many kidney donors, if you meet them, they tell stories of how great they feel about their kidney donation. They have the feeling of impact. They help someone else. They often believe in karma. They feel a sense of purpose. They contributed to improving life of others. So this is a great feeling to live with as a human being. The cons that it's a surgery, so it might come with short-term complications. They sometimes have developed some risk down the road. In general, if they become pregnant post-donation, like for female who opt to be donors, and they become pregnant post-donation, they carry 5% risk of having gestational diabetes or preeclampsia post-donation. It also has some financial pressure, and we ask a lot of questions. So we impact their confidentiality. So they tell us a lot about themselves. Now, speaking of the financial assisting programs we have for kidney donors, we have in the country, there are two programs. One is called National Living Donor Assistance Center, and the other one is called Donor Shield by the National Kidney Registry, the pair exchange programs that we mentioned. So the first one provides $6,000 per living donor for travel, lodging, and meals. They do depend on the income of the recipient. So your recipient have to show that they belong to, the benefits are tied to recipient household income. So they have to show that they belong to the low income population, and once they get approved for this, they don't ask for anything else. So they don't ask you for receipts or anything, and they pay upfront. So they assist with the flight, they assist with the hotel stay, they aid donors upfront. Where the NKR Donor Shield, they provide $6,000 per living donor, and they assist with all the other lodging, meals, and caregiver. They also provide $2,000 per week for lost wage and reimbursement. There is no recipient requirement for income. However, donors must participate in NKR swap in order to receive that, and they don't pay upfront. You save receipts and you submit it for reimbursement. So a little bit a different process. You don't have a qualification of lower income from the recipient standpoint. but also it's not as, you have to pay from your own money and get reimbursed. Now, what about post-donation? Most transplant centers follow up with patient post-donation at 6 months, 1 year, and 2 years post-donation to make sure they stay healthy and the kidney decline that happens suddenly pick up after 1 year and 2 years and become to the expected range. So the recommendation for future care is no different from the general population. So you're still expected to have your annual physical exam with a primary care, to go through the age-appropriate cancer screening. They should be advised not to take long-term drugs that can impact the kidney, such as ibuprofen or any drugs that can have a negative effect on the kidney. And I put this picture to remind myself of this story that we have one donor who donated at our center, sent us a letter of, being grateful and thankful. And she's a marathon runner. And she was able to run a full marathon 1 year post-donation. So that's how good our kidney donors do. You are expected to go back to your normal life, normal, healthy, active life. Kidney donation should not impact anybody's life. Otherwise, they're not suitable candidate, and the donation should, or the patient should not be cleared to proceed. Now, we get a lot of questions about how soon the kidney adapt to the change. When we remove one kidney, the body depends on the other kidney. And about 75 to 80% of the pre-donation GFR, recovered post-donation. Within 1 year post-donation, patients go to almost 75 to 80%. And we have a lot of patients who go back to 100% post-donation. So the kidney in the initial phase the numbers will decline, but down the road it goes through adaptation process and the functionality will pick up. What about urine albumin excretion? So we ask our kidney donors to eat healthy, and that's why I put this picture. But healthy is a very general word that some patients go back and eat too much protein. For example, I was reading about protein intake in athletes, and some of the rugby athletes, they have large muscle mass. They recommend 2 grams per kg per day. That's very high protein intake. So if you're going to take above 1 gram per kg, per kilogram of your weight per day, that means you are putting yourself at high risk of spilling protein. Remember, this kidney go through adaptation process, what we call it a hyperfiltration process, and you can see some protein spilling in the urine if you go for very high protein diet. That doesn't mean you have to restrict. It's just normal protein intake. Do not eat excessive amount of protein post-donation. Now, similar to the non-donating population, these kidney donors continue to lose 5 to 10 ml per minute of their GFR per decade of life, and that's an aging process in the kidney. So that solitary kidney that we leave after donation go through the same age process. Now, I just want to quickly highlight 3 questions. What proportion of kidney donors develop proteinuria? This is what the study asked and try to address. So let me go a little bit. And then, do kidney donors compared to healthy non-donors have higher urinary protein? So do they spill protein post-donation? They found that 7 years after donation, the average GFR was around 86 ml per minute, which is a very good GFR. And the average urine protein was 150 milligram per 24 hours. And that's considered a normal total proteinuria. So both of them are within normal range. Now, what about the third question? Do kidney donors compared to controls have an accelerated loss of GFR after initial decrement from the nephrectomy. And the rate of ESRD in the living kidney donors are similar to those observed in the general population. So the answer is no. They don't lose their kidney function faster than anybody in the general population who did not donate a kidney. This is an assessment of what kidney donors 10 years and 40 years post-donation face. What are the medical problems they encounter? And in this study, they recruited 9,500 donors, live kidney donors, with post-donation data analyzed. And they found the 4 most common events were hypertension as number 1 in 8.4% of the donors. So not everybody, but it's significant. And diabetes in 2% of the population, proteinuria in 1.8%, and some ileus in 1.5%. So, which is considered a general a surgical complication that happened shortly after surgery. So the most important one is hypertension in 8.4% and diabetes. I put this slide just to show you of a potential kidney donor and how many people get involved in every single donor evaluation. So we have a transplant coordinator, we have administrative assistant, evaluating nephrologist, a social worker, patient advocate, transplant surgeon, transplant nephrologist, dietitian, pharmacist, clinical nurse, and radiologist. We meet on a weekly basis and we discuss every case of living kidney or potential candidate for living kidney donation, and we decide about the different aspects of their care. I want to just shed the light on some innovation in kidney transplant. We have, we're part of this program, it's a tolerance study. We have it at our center. It induces immune tolerance, allowing recipient to accept the transplanted kidney without lifelong immunosuppression. This often involves mixed chimerism, where donor and recipient immune cells coexist after bone marrow or stem cell transplant. The final goal is to reduce rejection risk, improve graft survival, and no need for immunosuppression and all the side effects that comes with it. The caveat, they have to have 2 haplomatch, so they're often sibling, and even among sibling, not all, they need to have 2 haplomatch. So almost 25% of the sibling will qualify. We educate every patient or every couple who apply to UCLA about this study and if they wish to participate in it. Final thoughts, all what we do is to help our donors, to advocate for their health, to make sure we are not placing anybody at risk for kidney disease down the road. And I'm happy to take any questions.
Thank you, Dr. Abdelnawar, for just an outstanding talk. One thing that comes up sometimes when the parents are potentially donating to the children is guilt. How do you deal with that?
That's a very good question. So often the guilt is felt when the children donating to the parents, and
not the other way.
Not the other way. We see parents when the children are in need for kidneys, they're pushing and they're fighting us. Please take my kidney. So we feel like because it breaks their heart to see their children suffering or approaching the need for dialysis if they're not already on dialysis. So they become really adamant to move their case forward. Even when we ask them to do 1, 2, 3, they go and do it within a week, where we expect the process to take a month. So they are up to the task. They are excited to donate. That's when a parent to a child. When a child donating to the parent, we often see a pushback from the father or mother to accept the kidney from a child, and they feel the guilt. And that's a difficult feeling. So I can't tell you how many cases I encountered in evaluation where the child want to donate a kidney and they haven't told the parents yet. They want to make sure they're candidate because before they say that they don't want it or they won't allow it to happen. So they keep it secret until like the very end, and then when we clear them to proceed, they I went through the process and I'm a candidate. So we have multiple cases like that. So the guilt happened from the parents accepting, not giving.
And another thing that comes up with the deceased donor, they go to different programs. But sometimes we're asked for the living donation, can I go to multiple programs, either within the city or in different cities? What do you tell them, to stick with one only? Or
Yeah, so with a deceased donor, multi-listing is legal in the United States. You can list in few centers, and that's your right as a patient in need for kidney. And whoever offer you the kidney first, you go with it. On the donor side, because of the different criteria in different centers, we advise them to stick to one center. They can't be listed, in few centers in the city or in different centers in different cities, because every center, in general, living kidney donation, when a donor apply and get cleared, the process take 1 to 3 months. And then if everything is clear and smooth, within 3 months, they're donating and the process is moving forward. So it's a short pace, and it doesn't take a long wait time. It's very different from the deceased donor.
Thank you.
Yeah.
Does anyone on the call have any other questions for Dr. Abdelnawar? None at all? I have one other one, and that is, what percent of the donors get turned down typically in a typical program?
Wow, that's a difficult question. We receive about 1,500 applications per year. The maximum we have done is 130 donor surgery. So less than 10% get cleared because of all the medical problems I highlighted in my talk. So people with high BMI, people with diabetes, people with cancer, they often submit an application, and we have a process for filtering those cases. So almost 2/3 get filtered out from the first step with applications. But we know the total number because of the system allow us to see all the applications that get rejected and don't meet criteria, because we continuously looking for ways to improve our process, to look into cases that we probably rejected unfairly, or and we go through these cases and feel like, okay, every single one has some medical issue that do not qualify them to become a donor. So almost 2/3 of the application get turned down for different medical issues.
What are the big cancers that cause?
Well, the big one that is an absolute contraindication is malignant melanoma, like a skin melanoma. We don't take it even if it is like 15 years ago. It's considered an absolute contraindication. The others are like if you have breast cancer that you went through chemo and radiation, or ovarian cancer, or colon cancer. Prostate cancer, the criteria has been adjusted in recent years, especially in the very low stage of prostate cancer that become acceptable. So
these are in the donor that you're talking?
Yes.
Why would melanoma in the donor be an issue? They're not getting any.
Because it has very high likelihood of triggering cancer in the recipient.
Oh, I see.
So we learned from the recipient cases that we should never accept a donor with melanoma.
Wow. That's interesting.
Yeah, we always look at what's going to happen to the kidney and whether the donor going to do well. So we want both of them to do well, the graft to survive well and the recipient to do well without any infections or cancer or complication. We also want the person who donate to stay in good shape. So
And
Uh,
what percent in the donors are psychological? Is that
well,
common or uncommon?
in the recent years, I have to say it has become more commonly seeing antidepressant on the med list of young population. So a lot of patients who are young and healthy taking antidepressant or anti-anxiety, and usually we ask them to see a psychiatrist or have a letter from their psychiatrist that they have been in a stable mood on a stable, dose without any recent admissions or suicidal ideation.
So being on the medication doesn't preclude the donation. They just need the assessment from, I see.
Psychiatrist. Yeah.
Okay. Are there any questions for Dr. Abdenoir before we close the meeting? Okay, I guess everything was clear. Thank you so much for an amazing talk. I learned a lot, and I hope everybody else did on the call. Thanks so much for
Thank you,
taking
Dr. Kurtz,
it.
for having me. It's a pleasure.
It was an amazing talk. Thank you. Thank you.